Good afternoon, and thank you so much for joining us today for our Lunch and Learn hosted by the HIV and Aging Conference. This is our 12th year of producing the HIV and Aging Conference. My name is Rob Fabian. I am the Chief Community Engagement Officer at Age of Central Texas, and I've had the pleasure of chairing the conference for the past several years. So we are so glad that you're joining us for today's Lunch and Learn. We are recording this session and we will make it available after the fact. So if any of your peers were not able to join us, you'll be able to share the recording with them. I'll send all that information out after we finish with our presentation today. As this is a webinar, if you have questions that you would like answered during the presentation, down at the bottom of your screen is the chat button. Looks like one of those thought bubbles that you see in the comic strips. Click on that and enter your questions. And then at the end of today's presentation, we'll reserve some time for questions and answers. So it is my pleasure to introduce you to Dr. Joel Anderson. He is the Associate Professor in the College of Nursing at the University of Tennessee. And today we're going to talk about the RISE project. RISE stands for Research, Inclusion, Supports, Equity, And we're going to talk about the needs and experiences of the LGBTQIA plus caregivers and people living with dementia, as well as inclusive strategies for engaging that community and older adults who are living with dementia and their caregivers in aging research. So, Joel, I'm going to turn it over to you and let you take it from here.
Great. Well, thank you very much. Let me get my slides up here. And there, we should be good to go. So thank you, Rob, for that introduction and the invitation to talk today about our project and the work that we're doing. As Rob mentioned, it's the RISE project for Research, Inclusion, Supports, Equity. I want to tell you a little bit about how we got there and what we're doing, as well as share some information about caregiving for people living with dementia or memory loss in the LGBTQIA+ community. So as this is a federally funded project, I have to provide some disclosures. So I'm going to be talking about some of the research and the findings that we have from 2 grants that I've been awarded from the National Institute on Aging, which is part of the National Institutes of Health. You can see the award numbers there. And so the content that I'm presenting is solely the responsibility of myself and my co-authors and does not necessarily represent the official views of the National Institutes of Health. I have a colleague here at the University of Tennessee, Dr. Carol Myers, who often says that data make us credible, but stories make us memorable. And so I always like to start presentations, definitely in the community, but even professional presentations at conferences with a story about why I do what I do and how it's related to the work and the findings that I'll be presenting this afternoon. So in these 2 photographs, I'm in both. On the left-hand side of the screen, I'm the little baby there, and I'm seated with my great-grandmother, and then standing next to us is my grandmother. And this photo was taken in Cherokee, North Carolina, probably around 1978. And my great-grandmother developed dementia as she got older, and my grandmother became her primary caregiver. On the right, you see me in the middle there with one of my brothers sitting on my shoulders, and I'm flanked by my parents and my grandparents, and my brothers are there. And I watched as my grandmother took care of her mother, my great-grandmother, and put her own health needs on hold. She really wasn't paying attention to the things that she needed for herself. And my mom was a secondary caregiver during this time, helping my grandmother navigate all of this and manage things. And so she too was putting some of her needs on hold. And I tried to help as much as I could. I was in between undergraduate and graduate school at the time. My great-grandmother eventually died. And then once that happened, the after effects of that neglect and that lack of self-care from the caregiving aspect for my grandmother and my mother began to take their effects. And so over time, I became a caregiver for and have provided care for everyone in these photographs except for the guy in the headdress. Most recently for my dad, who died earlier this year. And so I was his primary caregiver at end of life. And so I was inspired by watching the process of caregiving that my grandmother and mother provided for my great grandmother with dementia. And that was the initial spark for my research program and my research into this area. But over time, as I've progressed through my own research career and have taken on various caregiving roles, particularly for older adults, particularly at end of life, that has definitely informed the work that I do and has inspired me to do even more in terms of community engagement and how do we make sure that caregivers are getting the information that they need and the resources to help support them, as well as how can we affect change in terms of policy, so that structures and resources and things are in place at all levels to support caregivers. And I really think that this quote from Rosalind Carter is so very true. Ms. Carter has said that there are only four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And it's so true. Caregiving is part of the human condition. And at any point in our lives, we're one or more of these four types of people, these four kinds of people. Um, as I said, I recently found myself in the role of primary caregiver and over time have cared for and been cared for everyone in the photos that I just showed you. Um, so it's really important that we think about how we're supporting each other in this role and the things that we need so that we can do it successfully. So I have a personal tie to Alzheimer's disease and dementia and caregiving, and most of us do. But it's also a national imperative. So these are some data from last year's Alzheimer's disease and facts and figures from the Alzheimer's Association. And Alzheimer's disease and other dementias remain one of the top 10 causes of death in this country. So you can see here from this infographic that 1 in 3 older adults die of Alzheimer's disease or dementia every year. And there are nearly or over 11 million adults in the US who are providing unpaid care for someone living with dementia. Our long-term care structure in this country really relies on family caregiving and unpaid care to fill those gaps. And Alzheimer's disease and dementias remain the costliest chronic condition in this country. And last year, it was estimated that $321 billion was spent on care and another $272 billion equivalent for those 16 billion hours in unpaid care. And in a few years, we're estimating that Alzheimer's disease care is going to cost us $1 trillion in this country as we're living longer and continuing to age in place. But many of us don't know the signs and symptoms of Alzheimer's disease and dementia or what we can do to stave that, as well as the resources that might be available to us if we're living with memory loss or caring for someone with memory loss. And as you can see there at the bottom of the infographic, 80% of people in this country have little or no information about mild cognitive impairment and early stages of Alzheimer's disease and dementia and what that looks like. So when I see numbers like that, when I see billions of dollars, hundreds of billions of dollars, and billions of hours, that's hard for me to comprehend. So I've done a little math. And when you think about the $321 billion that was spent last year for Alzheimer's disease care, that equates to $36 billion, $36 million an hour, every hour of every day that we're spending on care, direct care, medical care for someone living with Alzheimer's disease or dementia. But that doesn't include that $272 billion in unpaid care. So that's an additional $31 million an hour, just over $31 million an hour in unpaid care. And so that comes to nearly $68 million an hour every day every year, and it's only increasing. I have to update these slides every year to increase the number. And that's the amount of money, that's the cost, the economic cost in so many ways, in care and lost productivity, in debt that is being incurred by individuals and families in this country because of Alzheimer's disease and dementia. And so it really is imperative the work that my colleagues and I are doing is successful so that we can help stave off some of these costs, the economic impact, but also the cultural and the family impact. So what about our community? What about the LGBTQI plus community? So on your right, there's an infographic, and I'll be sharing these infographics with Rob afterwards so that they're available to you. There's an infographic there on the right from the Alzheimer's Association and SAGE, which is Services and Advocacy for LGBTQ Elders. And it really sort of summarizes the impact of dementia and aging on LGBTQI plus older adults. And a lot of it is based on research that my colleagues and I have conducted. And so you can see that we estimate that about 3 million people in our country, in the US, LGBTQI people over the age of 50 are living in the US right now. We don't have really great estimates because we don't always ask questions about sexual orientation and gender identity in a lot of our national surveys, but our best guess is 2.7 million or nearly 3 million people over the age of 50 identify as LGBTQI plus. And our community has greater health disparities when we think about a lot of the risk factors for dementia, like depression, obesity, alcohol and tobacco use, lower rates of preventative screenings and cardiovascular disease, as well as HIV and AIDS. So we estimate that about 7.4% of the LGBTQI plus population is living with dementia. Again, we don't have the best data right now, but we're working on that. But what we do know is that individuals in our community who are living with dementia have unique challenges in accessing support. 40% report that their support networks have become smaller over time as they've aged, and a third of them live alone. And up to 30% of them experience lower rates of access to care, whether that's a lack of providers in their area or a lack of healthcare coverage. And again, Alzheimer's disease is the most expensive disease in our nation. And roughly half of LGBTQI plus older adults report being worried about having enough money to live and afford the everyday basics. And 40% of them fear discrimination from healthcare providers related to their sexual orientation or gender identity. And so that might be one of the reasons why they're less likely to access the care that they need. So one of the data sets that we have at the national level that helps us understand things like risk for dementia and cognitive decline is known as the Behavioral Risk Factor Surveillance Survey. It's conducted every year by the CDC, and data are collected across the country. And so my colleagues and I use these data to try to understand the impact of subjective cognitive decline among the LGBTQIA plus community. So when you have neurodegenerative disorders like Alzheimer's disease and dementia that are marked by significant loss of memory and other factors, there are sort of preclinical stages to that can lead to risk of Alzheimer's disease. Sort of one step down from dementia is mild cognitive impairment, which is a level of cognitive impairment that is not yet to the stage of dementia, but does have an impact on day-to-day functioning and people's abilities to do their tasks. Before that, though, there's what we call subjective cognitive decline, where we've not necessarily crossed a threshold clinically, but we as individuals can recognize that our memory just isn't what it used to be, and we have some concern there. And so we wanted to look at that very early stage, that subjective cognitive decline among sexual and gender minorities. So sometimes you'll see sexual and gender minorities, sometimes you'll see LGBTQIA plus. But we wanted to look to see what impact this was having on our community. And so we used these data from the CDC to explore that. And what we found was there was an increased prevalence of subjective cognitive decline. It was much higher was reported more frequently among LGBTQIA plus adults, and that LGBTQIA plus adults with subjective cognitive decline who were experiencing these memory loss were more likely to report functional limitations as a result. They were having issues with completing activities of daily living and the things that they needed to do to get through the day, and they were saying that that was because of the subjective cognitive decline. What we found was that if we controlled for the level of depression, so statistically, mathematically, if we looked at this increase in subjective cognitive decline among LGBTQIA plus older adults, the overall increased risk, which was about 30%, so we were 30% more likely to be experiencing subjective cognitive decline. That was decreased a little bit when we took into account whether or not someone had a history of or a diagnosis of depression. That said, LGBTQIA plus adults were more likely to report a history of or a current diagnosis of depression and living with depression. And you may recall from a previous slide that depression is a risk factor for dementia and Alzheimer's disease. So we were seeing that relationship here between subjective cognitive decline and depression. So that's a little bit about the risk and some of the risk that we know that we have as a community and some of the research that we have looked at in terms of those risk factors and how they might play out in terms of subjective cognitive decline and mental health outcomes like depression. But what about caregiving? What does caregiving look like for us? Because again, the majority of people who are living with dementia or memory loss are relying on friends and family to help care for them. So in the general population, when we look at caregivers overall, and not necessarily just caregivers of people with dementia, but when we look at caregivers overall, in the general population, about 1 in 6 individuals is a caregiver. They identify as a caregiver of an older adult in this country. When we look at the LGBTQI plus population, that number decreases to 1 in 5. So we're more likely, more frequently, taking on caregiving roles than our non-LGBTQI plus peers. So one of the things that we did was to, again, take some national data from the National Alliance for Caregiving and AARP, and we wanted to look at were there differences in the experiences or the characteristics of LGBTQI plus caregivers of older adults compared with their heterosexual cisgender peers. And so we used these data from the Caregiving in the US survey. Initially, our first examination of these data was from 2015, and that was the first year that this survey asked a question about sexual orientation and gender identity. And what we found in this national data set was that LGBTQIA plus caregivers of older adults, now these were adults with dementia, these were adults with cancer, these were adults with lots of different chronic conditions, but overall, their caregivers who identified as LGBTQIA plus were significantly younger than their heterosexual and cisgender peers. They were also more likely to be members of other minoritized groups. They were more racially and ethnically diverse. We also found that LGBTQIA caregivers of older adults were less frequently the spouse or the partner of the person they were caring for. And they were more frequently a friend or a neighbor or a biologically unrelated caregiver. Yet they were helping with more medical nursing tasks, more involved caregiving than their heterosexual cisgender peers. So managing blood sugar, wound care, medication management, medical nursing tasks, those are the kinds of things that come up under that category. And LGBTQI plus caregivers were more frequently helping with these tasks. They also reported higher levels of physical, emotional, and financial strain compared with their heterosexual and cisgender caregiving peers. And LGBTQI caregivers who were the child of the older adult were 3 times more likely to report high levels of emotional strain than their heterosexual cisgender siblings who might be caring for an older adult. We think that this is probably related to the relationship, the quality of the relationship between the caregiver, who is identifying as a sexual and gender minority, and the person they're caring for. And what does that relationship look like over time? Has that always been a supportive relationship? Is it a supportive relationship now? And so we think that that is part of the reason why LGBTQIA child caregivers, the children of the people they're caring for, are 3 times more likely to report significantly higher levels of emotional strain. So we looked at that data set because it was a nationally representative data set, and we were hoping that it would have a good, robust sample of people being cared for who were living with dementia. But even though it was a national data set and there were lots of people in that data set, when we whittled it down to the LGBTQI plus caregivers of people with dementia, there were only 11 people in that data set. So that's why we had to take it one step up and just look at older adults. But we were really, really interested in what is happening among LGBTQI plus caregivers of people living with dementia or memory loss. And so we got that first grant, that R03 preliminary grant from the National Institute on Aging. I led that study, and we specifically looked at the characteristics and experiences of caregivers in our community who were caring for someone with dementia. And that's because a lot of the national data sets that existed at the time and currently don't ask questions about sexual orientation and gender identity, or if they do, they might not ask questions about caregiving. And when you do find that sort of sweet spot of questions about sexual orientation, gender identity, and caregiving, the questions that they ask are limited, and a lot of times are just related to demographic characteristics. And we were really interested in measures of well-being and overall quality of life, and things that really were just missing from the publicly available data at the time. So we had a community-based study where we looked at caregivers of people living with dementia, specifically our LGBTQI plus caregivers, and what their experiences were like. So in our sample, this is a breakdown of our sample. We had 286 caregivers in our sample, and we collected data electronically using social media recruitment. So we had data from across the country. And the majority of our sample identified as gay men, but you can see that we also had lesbian women, bisexual men and women, and then those who identified as pansexual, queer, any other identity. People were allowed to tell us how they identified. For data analysis purposes, we put them in a category that we labeled queer, but you can see that we had representation across multiple sexual orientation identities. And we also had a substantial portion of caregivers who identified as transgender. So we're really glad that we were able to recruit all of those people, because it allowed us then to look at differences across different sexual orientation identities as well as gender identities. So some of our key findings and overall findings, almost all of the caregivers in our sample, 63%, were caring for someone who identified as lesbian, gay, bisexual, or queer. And 20% of our caregivers were providing care for someone with transgender who identified as transgender. So again, we were able to see a diversity of experiences and really feel good about the data that we collected. Much like what we found before, the caregivers in our sample were significantly younger. In fact, the caregivers in our sample ranged in age from 21 to 72, with the majority of them being in the millennial generation. So they, at the time that we collected these data in 2019 and 2020, they were under the age of 40. 36% were in Generation X, and 5% identified as baby boomers. Now, the majority of the caregivers in our sample identified as white, but over a third identified as Latino America, Latino, Latina, Latine. So we were really glad that we were able to get a diversity of experiences in that regard. And we met or exceeded our recruitment goals and our engagement goals for African American, Asian, Native American, and Pacific Islander caregivers as well. So again, much like what we had found before, LGBTQI plus caregivers of people with dementia are also more racially and ethnically diverse. Just over half didn't live with the person they were caring for. Now, that could be because the person they were caring for was living in a nursing home across town, or maybe living alone across the country. We had to balance the number of questions that we asked them with the things that were most important so that we didn't overwhelm them. So we don't know where their care recipient was living if they weren't living with them. But over half were caregiving from a distance. And again, that distance could have been across the street or across the country. Half were caring for their spouse. But again, 10% were caring for someone that they consider that was a friend that they were not biologically related to, but may have considered chosen family. A third were living in a small town or a rural area. So not everybody was living in a suburban area or a metro area. And while about half of the respondents were living west of the Mississippi, again, we had representation from all regions of the country. 9 and 10 were working full-time or part-time where they were providing care. And this isn't surprising when you consider that a lot of our caregivers in our sample were in their 20s, 30s, and 40s. And while they reported an overall sort of good income and high income, a third said they found it somewhat difficult to afford everyday basics. And when we broke it down and looked at different sexual orientations, queer caregivers and bisexual caregivers were the ones that were reporting the most difficulty. A third, well, just over a third of the caregivers reported a below average health status, and a third were also living with a chronic condition of their own, at least one that they were having to self-manage, while also caring for someone living with memory loss. We expected numbers to be high related to stress and depression, but we didn't expect them to be as high as they ended up being. So nearly 3 in 4 caregivers, so almost 3/4 of our sample, reported moderate to high levels of stress. Now, this was perceived stress, so this could be stress related to job, this could be stress related to caregiving, this could be stress related to everyday life, it could be stress related to all of those things. 78% experienced symptoms related to depression that were above the clinical cutoff for probable depression on the scale that we used. The prevalence rate, the rate of depressive symptoms reported in the overall caregiving sample and among cisgender and heterosexual caregivers is 30 to 40%. So LGBTQIA plus caregivers were reporting depression at twice that rate. Again, we expected it to be high because we know that our community experiences disparities in terms of depression and anxiety, but we didn't expect it to be double the rate. What we were pleased about, not a necessarily shocking finding, but something that we want to explore further. Trans caregivers reported better scores on all of the well-being, psychological, mental health scales that we use, despite reporting a lower than average health status. So even though their overall health status was lower than the cisgender caregivers, their depression scores, their quality of life scores, all the other scores were better than the cisgender caregivers. And so we think that this is probably related to the level of resilience of the trans community and other factors that we think that, living your authentic self gives you a level of strength that can help you overcome some of the issues that we were looking at. But again, this is something that we want to explore further. So we've been gathering all these data and analyzing all these data to try to figure out what's going on with LGBTQIA plus caregivers and people living with memory loss, and how we can develop culturally appropriate, tailored, useful resources and interventions for our community to support these individuals, because we recognize that there are disparities that exist. National organizations recognize these disparities. And so when we were looking at the sort of overall picture, what came to the forefront for us for this project and some of our others was that concept of equity. I have a colleague at Emory University, Dr. Ethan Cicero, who looks at transgender health among older adults, or older transgender adults and their health. And when we were working on a paper, he said, it's not that they're not collecting data from us. We're in those national surveys. We're there. They're just not collecting data about us. Because if you don't ask questions about sexual orientation and gender identity, then we can't begin to understand what some of these disparities look like and why they exist and what we can do about them. And then when we do have studies that are looking at an intervention or want to explore something more fully, again, we're not asking questions about sexual orientation and gender identity, and we're not specifically making sure that we're including LGBTQI plus individuals in aging research. So there's a real equity issue in terms of aging research. And about the time that we're figuring this all out and sketching this all out, the National Institute on Aging had a specific call for funding about how can we as a research community increase equity for underrepresented and minoritized and marginalized populations in aging research. And so we applied for funding, and of all the projects that were funded, ours was the first and the only one under this particular mechanism that is specific to the LGBTQIA plus community. And so we called the project RISE, for Research Inclusion Supports Equity. And we were inspired by the title of Cleve Jones' memoir, When We Rise, as well as thinking about Phoenix and rising from the ashes. And so that sort of gave a name to and a symbol for our study and what we're really interested in. And so this is the team on the study. My photo is missing, but I'm one of the co-leads of the study at the University of Tennessee, along with my colleague Whitney Wharton at Emory University and Jason Flatt at the University of Nevada, Las Vegas. I also have as co-investigators Maritza Dowling at George Washington University, who has expertise in creating research registries and issues related to the scales that we use to measure things like depression and anxiety. Dr. Andrea Gilmore-Bukowski at the University of Wisconsin-Madison, whose work focuses on the inclusion and the involvement of African American and Black caregivers. We have Dr. Jaime Perales-Puchal from the University of Kansas, who focuses on Latino caregivers. And then as a consultant on the project, we are very grateful to have one of the leading researchers in Alzheimer's disease and dementia, particularly in the area of health equity, Dr. Jennifer Manley from Columbia University. And our project is really focused on how do we ensure, through a collaborative, community-focused effort, that our community is involved in and has the opportunity to be involved in aging research, specifically around memory loss and caregiving. And so we have three main aims of the study, and we're now in the third year of this 3-year project. And so we've really gotten a good handle on aims 1 and 2. Aim 1 being to form a network within our local communities and across the country of community members and service providers, researchers, caregivers, people living with memory loss to help inform our work. And then to establish a research registry, which we hope will have at least 1,000 people in it. And right now we're over 900, so we're very close to that, of people either living with memory loss or caring for someone with memory loss who identify as a member of the LGBTQI plus community, so that we can give them opportunities to be involved in aging research studies across the country, but also talk to them and collect data from them about the best ways of developing, implementing, and evaluating how do we get our community involved and what are some of the needs that are most pressing for our community. And we're beginning to work on the third aim, which is to develop a model or models for recruitment and retention of our community in aging research that we can share with aging-related clinical researchers, with the Alzheimer's disease research centers that are dotted across the country, so that going forward, our work, as well as the work of others, can be sure that our community is involved. We have a national advisory board with the members that you see here. So folks like Carl Hill, who is the Chief Diversity Officer of the Alzheimer's Association, Lisa Krinsky, who is at the Fenway Institute. We have Ana Machado, who is at Centerlink, which is an overarching group that connects and supports community LGBTQ centers across the country. We also have caregivers who've started their own caregiving business, like Xander Keek, who's a transgender caregiver. And then we have folks from SAGE, the Family Caregiver Alliance, all across the country to help us better understand how we can engage and work with our community, but also that gives us reach across the country. And so through our national advisory boards and our community advisory boards and our 3 sites, we have our fingers and fingerprints in all the states across the country, including Alaska and Hawaii, as well as Puerto Rico, particularly through that connection with Centrelink. So that allows us to get the word out at events like this in Austin, as well as other places across the country. One of the ways we're also doing that is with our social media presence, because we know from our research that LGBTQI plus adults more frequently use social media, and they more frequently use social media and the internet for health-related purposes. And maybe that's because of those access issues, either because they don't have access or because they fear discrimination. But we know from a lot of research that we've done, as well as others, that our community is online, engaged more online. And so that's a good place for us to be, to share the work that we're doing. So for example, we just worked with Miss Coco Peru, who did a little short video for us describing some of her own experiences in caring for her mothers living with dementia, and also to let folks know about RISE and how they can become involved. RISE really is community focused. It's community engaged, it's community driven. And so our community advisory boards and national advisory board meet every 3 months to help us tease out the things that we're learning and the things that we want to move forward with. We're also constantly at community events, whether they're virtual or in person, because all 3 of our main sites are in rather hot areas of the country. October was a big month for us in terms of Pride events in Tennessee and Georgia and Nevada. And at these events, we're talking to caregivers, we're talking to older adults, we're talking to people living with memory loss and trying to understand the best ways of engaging them. And one of the things that we're finding that we're beginning to work on is that folks are not necessarily seeing themselves as caregivers or care partners. So we've tried different languaging and we're wanting to explore this further. And maybe that's one of the reasons why our community isn't accessing the resources, because they don't identify themselves as a caregiver. So they might say things like, oh, I'm not there yet, I'm not that old. But my mom moved in with us and we've been caring for her for the last 5 years because she has problems with her memory. I'm like, well, that's caregiving, that's providing care. You are a caregiver, you are a care partner. So we're beginning to think about how we might incorporate that into that third aim of helping people to understand what caregiving is, what caring for someone looks like, and by the virtue of them understanding that, what resources are available to them. So our project has a website, theriseregistry.org, and on that website you can find information about the registry, as well as resources and other studies that are happening across the country, all of which we've vetted. And when you go to sign up for the registry, it's a very simple process. We only ask a few questions, but those few questions then help us tailor the information that we send to you. So we need name and age and contact information, phone number, email, and zip code, race, ethnicity, gender identity, sexual orientation, whether or not the person who is signing up is living with memory loss, caring for someone with memory loss, or both. It could be both. And the types of research studies that the person is interested in. Are you just interested in completing some surveys? Would you like to participate in an online interview or focus group? Would you like information about more clinically focused research? And then we can take all that information and tailor the opportunities that we send to people in the registry. So if we are looking for, and we currently are, recruiting caregivers to understand their experiences, whether that's through an online interview or a focus group, then we can specifically look at those individuals and send emails to those who said they're a caregiver and they're interested in doing an interview. If we have someone approach us and we go through and vet their study and they're interested in African-American lesbians living with memory loss, we have that information, and so we can target the email and only send it to those people who are interested in that type of study, instead of bombarding everybody on our registry with every single email that we send out. So we're trying to make it as focused and productive as possible, either through focus groups, interviews, targeted opportunities to be part of research, but also we want feedback from folks so that we are understanding what what are you looking for in terms of resources? What is your experience like? If you're interested in research, what type of research you're interested in? If you're not interested in research, why is that? What are some of the barriers there? How can we help address those and potentially overcome those? So again, all vary from a community focused standpoint and what we can learn from our community. So what are some of our next steps? Well, just a couple of months ago, based on the data that we had before, as well as the things that we're learning through the RISE project, Jason and Maritza and I received another grant from the National Institute on Aging. This is a 5-year grant, a multi-million-dollar grant, to begin to look at the types of questionnaires and surveys that are used in caregiving research, particularly caregivers of people living with dementia, and whether or not they work for us. A lot of those surveys were developed 30, 40, 50 years ago in a different social and cultural context, and are quite heteronormative and focused on traditional family structures and focused on outcomes and ideas and concepts that might fit that particular type of caregiver. But what we know from the overall caregiving population now is that it is way more diverse in terms of race, ethnicity, age, sexual orientation, gender identity than when these surveys and questionnaires were developed 40 and 50 years ago. And so our new project that is dovetailed very nicely with RISE is to understand what are those important surveys and questionnaires? Do they work for us? And if they don't, how can we develop and test new ones that work for a more diverse population of caregivers, specifically LGBTQI plus caregivers? And as I mentioned, we're still in this stage of wanting to talk to as many caregivers and people living with memory loss as possible. And because we're a national study and we're doing so much of it online, all of these interviews and focus groups are virtual. Now we can come and meet with you in person, but this overcomes some of those barriers to participation, like transportation issues, et cetera. So again, I'll share this information with Rob, but if folks are interested in being part of our study and letting us know what their caregiving experiences have been or what their experiences with memory loss have been, we'd really, really like to hear from you. And there's a small compensation that's included in that. And you can contact me, or as I said, Rob will have the contact information that he can share with you. So with that, I wanted to make sure there's plenty of time for questions. It looks like we've got like 10 or 14 minutes for that. I really appreciate the opportunity to talk to you. This QR code will take you to the RISE website. But again, all that information will be coming to you after the fact. So I will stop sharing and happy to answer questions.
Thank you so much, Dr. Anderson, for all of that great information. Yes, if you have a question, go ahead and type it into the chat and we will answer those for you since we've got a little time left. Dr. Anderson, I did have a couple questions that I wanted to throw out there. In your initial information, you talked about how among LGBTQ plus older adults, there was a higher level of cognitive decline. Has any of your research pointed toward why that is?
So that we have a lot of ideas about that. And so I think that what we saw in our previous study with the level of stress and depression could be leading to that, because we know that depression is a significant risk factor for dementia and memory loss. We also know that stress is a significant risk factor for dementia and memory loss and for cardiovascular disease, which also puts you at increased risk for memory loss. So a lot of the things that we hear in terms of the disparities that the LGBTQI plus population experiences across the life course, from young adults and adolescents dealing with anxiety and depression to middle-aged LGBTQI adults dealing with COPD and asthma and cardiovascular disease. All of those things put us at increased risk for dementia and Alzheimer's disease. And so a lot of it we think is the stress related. One of our sort of frameworks that we're using is the minority stress theory, that when you have all these different overlapping minoritized identities, including sexual orientation, gender identity, that it increases your overall stress. And so Dr. Wharton is very much interested in what that looks like from a physiological and biological standpoint. So she does a lot of studies where they collect blood and cerebral spinal fluid to look at inflammatory markers and markers that are related to the mechanisms of Alzheimer's disease and dementia. And so again, we have to crack the code on making sure our community is included in the research so that we can begin to understand really what's going on. But a lot of it seems to be pointing toward those mental health outcomes and the cardiovascular disease outcomes.
And to that end of making sure that we are represented in these types of surveys and this research, has there been much research into those who are living with HIV and their rates of dementia?
Yes, so Dr. Mark Brennan-Ing, who is on our National Advisory Board, that has been his scholarship for many, many years. So he is in the Northeast. I'm blanking right now on his institute, but he's been looking at the population of individuals living with HIV and AIDS, and particularly the older population, and the impact on cognition, cognitive decline, and overall health. So we're really pleased that he's part of our study, because he's always making sure that we're taking that into account as well.
Right. Yeah, I'm kind of in a unique position. I'm caring for my husband, who is living with early onset of dementia. He's been HIV positive now for 32 years. And so we know that his is definitely HIV related. And I'm also primary caregiver for my parents. So in your research, have you seen any differentiation between those who are caring for a partner and those who are the children caring for their straight parents?
Yeah. So we have seen some differences there. Like I mentioned earlier, when we LGBTQI plus children of the person, either the older adult with a chronic condition or the older adult with dementia, they seem to have higher levels of strain, higher levels of stress, higher levels of depression overall. And a lot of that we think is related to the quality of the relationship. So oftentimes there can be a difference between the quality of relationship you have with a partner or a spouse versus a parent or a grandparent or an aunt or an uncle, because we're often taking care of lots of folks in our family. And those are some of the things that we want to tease apart, particularly in this new project, where we look at the types of measures that are asking these kinds of questions, because they're not asking questions that reflect the family structures that we commonly have. So in our previous research, at the end of all the surveys, we left some open-ended questions about, tell us what we need to know, and were any of these questions hard to answer? And a lot of people wrote that, I know you said that we get to tell you who our family is, but when I would see the word family, I didn't know if you meant my bio family, my chosen family. So sometimes I thought about my biological family, which is not supportive, or sometimes I just talked about my chosen family, which is very supportive. But that's because the questionnaires that we have don't work for us. So there is this concept of familialism, and that scale, that existing measure, is completely heteronormative and traditional family structure. So we absolutely would have to adapt it and change it to be able to use it for our community. So we just have some inklings about these things, and we need to do the work that we've been funded to do to begin to figure those things out. But that's why it's important to be able to talk to caregivers like yourself and others, so that we can begin to understand, how do we ask those questions, and what are the concepts we need to be exploring.
Yeah, there's such a generational difference as well among the LGBTQ plus community. My generation was the one where we stayed in the closet because we would get cut out of the family
Right.
and or lose our jobs. And
Right.
then you've got the younger generation who are in caregiving roles that they have had the opportunity to be out for the majority of their life. And
Hmm.
so, the concept of family is very different between those two generations. And just the life experiences are very, very different. And
Absolutely.
and all
The
of that, we bring to the table as caregivers.
Yeah, the strongest predictor of any and all of the measures and outcomes that we included in our previous caregiving study was microaggressions. Those individuals who experienced more microaggressions had higher depression scores, higher stress scores, lower quality of life scores, lower health scores. It was a predictor of everything in our study. And we used a microaggression measure that was specific to our community and experiences of microaggression related to one's sexual orientation or gender identity.
And of course, you add into that our cultural issues as well. My experience as a white gay man as a caregiver
Yes,
is going to be much different than a Latinx or African American female lesbian,
right,
because
absolutely.
you've
So,
got so
yes,
many other cultural issues besides just being LGBTQ that come to play.
right. We found in our study that African American LGBTQI plus caregivers had the highest levels of depression, and that uh, mostly white, but the gay male caregivers had the highest levels of family quality of life, but they also had the highest levels of caregiver stigma. And we think that that might be related to the traditional gender roles that we expect women to be the caregivers in our society, and when men are caring for their mothers or their aunts, or that yeah that there's stigma involved there. I say there's a question about does the study include transgender individuals with dementia? We definitely want to include transgender individuals with dementia. Our previous study, the data that I presented was for caregivers, and so 20% of those caregivers were transgender and they were caring for transgender people with dementia. We didn't get a lot of information about the person with dementia in our previous study. We were really focused on the caregiver. But in our current study, we absolutely want to talk to people with dementia who also are trans, and we want to explore how do the measures that exist take that into account as well.
So, since Central Texas has one of the larger communities that are LGBTQ, and on top of that, we have one of the larger communities that are caregivers as well, how can we help you with the study, with the research? What can we do as organizations who serve older adults help to further this research and getting the word out about this registry?
Yeah. So, like I said, I'll be sending you the flyers and all the things. But if folks go to our website and sign up, that's the best way, because then we can reach out when we have interview opportunities or focus group opportunities or other surveys. You can contact me directly if you know you want to be in an interview. We can go ahead and get that started. And again, on the website, we also have a resources page where we're trying to, at the very best, give some resource recommendations for each state. And but we sort of we have that guided by who's signing up in the registry. So if we don't have anybody from Delaware, you might not find Delaware on there, but I'm sure we got people from Texas. So we're trying to list places on Texas. So we're trying as much as possible to work together, but also, what can we do to support you in the work that you're doing? What information can we provide? What resources can we point you to? Um, we don't want to just be showing up and being like, hey, help us. Um, we want to really be collaborative in all of this. So we are always down for webinars, lunch and learns, creating new infographics. One of our community advisory board members here asked me, she's like, can you create an infographic about that that's more specific to Tennessee? I'm like, sure, we can do that.
Wonderful. Well, Dr. Anderson, thank you so much for taking your time to visit with us today. We appreciate all this great information because this is some tremendous statistical information that can help us as organizations in the service that we provide in the community. And such a wonderful project. And for those of us that are caregivers in our community, it's great to know that we are being supported in our work. So thank you so, so much for joining us today.
You're most welcome, and thank you for all the work that you're doing. And I hope that the conference next month, it's just a few weeks away, is a great success because I know how valuable it is.
Thank you so much. And thank you for all of you for joining us during your lunch today. We really appreciate you taking the time to learn about the RISE registry and all of this great research. Hope that you will get in touch with Dr. Anderson. And if you've got caregivers that you are serving, that you'll pass this information along to them as well. As promised, I will send out all of this information. Probably will not happen today, but as soon as I can, I will get that all out to everybody who signed up to be a part of the webinar today. And as mentioned, the HIV and Aging Conference is coming up on December the 1st, which is World AIDS Day. This will be our 12th year of presenting the conference with great information from experts throughout the area, talking about how we as organizations and as care providers in the industry can better serve those who are living with HIV and who are aging. You can go to our website of HIVandagingconference.com and you can sign up today. The conference will be in person at Norris Conference Center and will also be virtual. So you don't have to come in person if you're not able. And we will also be offering CEUs with that as well. Once again, Dr. Anderson, thank you so very much for joining us. Thank you for joining us and being a participant in today's program, and watch your emails for all of the resources coming to you. Hope you have a great rest of your day and a wonderful weekend. Thank you so much.